just welcome everybody to tonight's program with Dr. Lee. The Lethbridge Public Library and Healthy Lethbridge acknowledges that we're gathered on the lands of the Blackfoot people of the Canadian Plains and pay respect to the Blackfoot people past, present, and future, while recognizing and respecting their cultural heritage, beliefs, and relationship to the land. The city of Lethbridge is also home to the Métis Nation of Alberta, Region 3. I'm going to turn things over to Trish York, and she will be giving an introduction for Dr. Karen Lee.
Well, hello everyone, and thank you very much for joining us this evening. Our Healthy Lethbridge group is just absolutely delighted to have Dr. Karen Lee join us. She is, and let me get my notes because there's a lot to share about this wonderful woman and her, incredible work that she's doing. She has a book called Fit Cities. So how I learned about Dr. Karen Lee is I tuned into the morning news about maybe a year ago here in Lethbridge, and there she was out of Calgary doing a presentation talking about fit cities. And I was enamored, I was intrigued, I was inspired. And so I mentioned it to our president, Heather Mathur, with Healthy Lethbridge here in our city. And we learned that she has a book, and she just represented all the things that we're trying to do here in our lovely city. So, thanks to Heather for reaching out to Dr. Karen Lee, and we're just thrilled. And so I wanted to share just a little bit more about Dr. Lee. She is the author of Fit Cities, as I mentioned. She's an internationally renowned public health expert. This is a quote about her work. Dr. Karen K. Lee is a force for good around the world, working behind the scenes to help people improve their diets, get in shape, and live longer. In the early 2000s, smoking was in decline, and so the US CDC's attention had turned to the next biggest cause of premature death: overeating and under-exercising. Dr. Lee's zeal and enthusiasm in seeking out the root cause in schools, restaurants, and environments that encourage a sedentary, calorie-packed way of life. She was next recruited by the city of New York, so her work continued to grow, where she was instrumental in introducing active design, an initiative for creating opportunities for healthy living in everyday life. The world around us needs to change. Dr. Lee, she's helping us do that. She has been a pioneer in addressing today's leading health problems, such as obesity, heart disease, strokes, cancer, and diabetes. Fit Cities, her book, is a riveting memoir of the important work that she is doing. It offers invaluable advice on how we can all help ourselves to live healthier lives. Dr. Karen Lee is an associate professor in the Department of Medicine at the University of Alberta here in Edmonton, in our amazing province of Alberta. So what a treat that we have her back in Canada and in our province. We are just thrilled to learn from you tonight, Dr. Karen Lee, about how we can be a healthier city here in Lethbridge. Dr. Lee, thank you. Over to you.
Thank you so much, Trish, for those kind words. I was going to say that I'm going to, start by doing a few excerpts from a few excerpts from the book. Okay. But I think it would be great if we have time after to, hear the thoughts of folks like yourself and others on the call and your experiences with, what has been working, what you guys have been able to make progress with in the Alberta and Lethbridge context, and what you feel are additional things that we need to work on, in the Alberta context. I've been away, I think, from Canada for a while. I did grow up in the Edmonton area. I went to U of A and did my undergrad and medical schools here before going to Toronto to do my master's, the equivalent of a master's of public health, and also a residency in public health and preventive medicine. And then I worked for a little while actually in Alberta when, we still had the different health authorities before everything amalgamated into AHS. And And then subsequently, I went down to the US. I'm thrilled to be back. I think some of the things that I've learned from around the world, I've tried to capture in the book as a way to share it with different folks. And the book is really meant for, certainly for professionals interested in this area of work, but also for the general public, right? Because if we, I think if the public isn't thinking about these issues, then we may not have as much political will as we need to get, I think, some of the policy things done that can really help us to improve the environment. And then also, if industry, like developers, as an example, home builders, if they don't have a sense that people care about these issues, then there's also no impetus for them to change their practices and make, whether it's new developments or retrofits that we're making to our communities healthier. So I think I was really thrilled when the publisher came to me and said that they wanted to do a book that would be, readable and accessible by the general public. I'm also thrilled to be back. I see actually a couple of members of my team from U of A. So I have currently an initiative, and folks here who are attending, if you guys want to join us and our partnership working group after this call, feel free to, I think you could probably reach me through Jonathan or Trish, and they can forward on your emails to us and we'll get back to you. You could also get in touch with h4h@ualberta.ca. That's capital H and then FOR, capital H, @ualberta.ca. That stands for Housing for Health. So we've got an initiative right now. It's a 5-year initiative funded by the Public Health Agency of Canada. And what we're trying to do is recreate some of the successful processes that are needed, that have been shown in other parts of the world that are needed to really create successes in changing our environments of our communities. And by changing those environments comprehensively in different settings, daycares, schools, work sites, our healthcare systems, but also our community settings, including grocery store settings, restaurant settings, by doing the gamut of, walkability of our communities, bikeability of our communities, by doing the gamut of things, we've shown, for example, when I was working in New York, that we can actually reverse the epidemics that have been rising over the last few decades, like childhood obesity, like, the chronic diseases like heart disease and strokes, diabetes. And this is particularly important now. I know we're living in a time when we're in a pandemic with this infectious disease called COVID, but studies are showing us that if you have these underlying chronic conditions and risk factors like obesity, you're actually at risk of increased severity from infections like COVID. And so even though we're in this infectious disease epidemic and pandemic, it actually is really vital that we tackle the issues that are making these underlying conditions like diabetes, heart disease, cancers, very prevalent in our communities. So with that, I'm going to stop and I'm going to read some excerpts from this book called Fit Cities. I want to thank the Lethbridge Public Library for inviting me, as well as the Healthy Lethbridge Initiative for inviting me. And then after my reading, we'll open it up for Q&A, and also I would love to hear the thoughts of those that are on this call. I think many of you do work in this area of chronic disease prevention, of healthy living, of trying to make our communities healthier. And I would love to hear you share your expertise and your thoughts as well. Okay, so I'm going to start with Just some excerpts from the book. All too often, health is considered to be a personal responsibility. In countless books and articles about diet and exercise, in countless television show segments dedicated to issues like weight loss, we're told what we need to do to change in order to achieve better health. But many of us already know these things. In fact, one of health education's major successes over the last several decades is this widespread knowledge of the need to modify our behavior. We know what we need to do. Year in and year out, our top New Year's resolutions are weight loss, exercise, healthier eating. But for many of us, it makes no difference. Year in and year out, we are getting less healthy, we're gaining weights. So what's going on? To answer these questions, we need to think about those New Year's resolutions again. The whole idea of a resolution is to resolve, to decide firmly on a course of action. We must resolve to make changes. We must choose to do whatever it is in our power to do in order to succeed. As it turns out, the last part is key. Whatever is in our power to do. All of our heartfelt and determined resolutions to lose weight, eat better, exercise more, come with a subtle built-in assumption that we can lose weight if we choose, we can eat better if we choose, we can get more activity if we choose. But what if we can't make that choice or make it easily? What if that's not really within our power to do? We can only make healthy choices around eating if stores and restaurants near our homes have healthy items on offer. We can only walk to work or walk our children to school if the sidewalks are in good condition or there at all. We can only encourage our children to get outside and play, kick a ball around, if there's a safe playground or park nearby. The commonly held assumption that weight loss and health is a battle that we have to fight alone has caused us to fail miserably in our fight against chronic diseases and obesity. Rates of these conditions around the world continue to skyrocket because we place the blame solely on individuals rather than on the environments in which we live. We continue to prioritize willpower over access to healthy food. We continue to stress the importance of individual dedicated exercise over the importance of creating opportunities for active living in the places where we spend most of our time, where we live, work, and play. If we want to reverse the trends of the last several decades, we need to start a new conversation, one that's radically different from the ones we've been hearing about in the news, reading in the pages of books and magazines over the last little while. We need to talk about how and what society, the collective we, can do better. We need to talk about how to create environments that will help rather than hinder our quest to become healthier. And you know, it's not that I just believe this. I actually know it. Nearly a decade and a half has passed since I started helping cities and organizations to improve the environments where we live, work, and play. I've worked with health departments, with planning departments, with mayor's offices in many cities, including now in Edmonton and Alberta, and also in places like New York City. I've been involved with a team of U.S. Centers for Disease Prevention and Control, or the U.S. CDC disease detectives, in groundbreaking field work that looked into what were potential causes of an obesity outbreak. I've traveled to Bogota, to Singapore, to Sydney, to Sao Paulo, to the UK, to the Netherlands, and many other parts of the world to consult and to learn. Through it all, one thing has become abundantly clear, that our success depends not only on ourselves, though we certainly have roles to play in choices that we make, but also on the physical and social environments that we create in our cities, our communities, and our organizations. If our cities, our towns, and our organizations become more fit and healthy, we too will find it easier to become fit and healthy. So now I'm going to read you some excerpts from stories in the book. April 24th, 2005. More than a decade later, I can still remember how it felt to touch down at Yeager Airport in Charleston, West Virginia. It was a sunny Sunday afternoon, and I was beyond tired. The week leading up to the flight had been a hectic blur, and 6 months prior to that hadn't been any easier. Meetings, phone calls, email exchanges, countless late nights designing and redesigning documents and tools. Shopping expeditions for clipboards and clicker counters and computer software. Not to mention the packing and repacking of heavy suitcases, desperately trying to make everything fit. But finally, we were here, a team of disease detectives sent by the US CDC to investigate the state's obesity outbreak. Yes, you read that right. The world's foremost organization in the fight against the spread of infectious diseases, frightening, highly contagious diseases like Ebola or Zika, had now sent a group of public health professionals into West Virginia to study its obesity outbreak. We were particularly interested in the circumstances behind the state's shockingly high rates of non-contagious diseases. In West Virginia in 2004, West Virginia ranked third among US states for obesity and first amongst one of its consequences, high blood pressure. The state ranked second for diabetes, another health condition associated with the obesity epidemic. More than 10% of adults in West Virginia had diabetes at that time, compared with 6% in the rest of the country. An epidemic, also called an outbreak, is defined as the rates of disease above expected or normal levels. So based on those parameters, West Virginia was indeed suffering from outbreaks of obesity, diabetes, and high blood pressure, even when compared to the already high rates in the rest of the country. The question then was, why? Our 3 weeks in the field in West Virginia whizzed by. Before we knew it, our time in West Virginia was coming to an end, and a mountain of work was awaiting us in Atlanta, where we had to compile our findings into a report. On June 2nd, just a few weeks after we arrived home in Atlanta, CDC Director, Julie Gerberding, announced our study at a press conference. The New York Times broke the story, stressing the unprecedented nature of our work. Time reporter wrote, the Centers for Disease Control and Prevention has sent a team of specialists into a state, West Virginia, to study an outbreak of obesity in the same way it studies outbreaks of infectious diseases. In the days that followed, the story spread to CNN, the Associated Press, countless other American outlets. In the UK, The Guardian had picked it up. It would take months to analyze fully the data we collected and to truly document why West Virginia was at the center of an obesity outbreak. But those of us who'd had the boots on the ground already knew what to expect. Having visited the schools, the work sites, supermarkets, convenience stores, and restaurants, having walked the streets around these premises, having walked the state park's unusable, overgrown trails, we knew that our data would reflect just what we had experienced. That the healthy choices that people wanted to make, the healthy choices they wanted their children to have, were not so easily found. In West Virginia, the deck was stacked against those who wanted to live healthier lives. Was that same truth also occurring in other cities in North America and around the world? So from West Virginia, I'm going to take us to the suburbs of New Jersey. It's a wealthy suburb of New Jersey. And we're going to talk about how dire the state of children's health are today, from issues like lack of physical activity. So this is from chapter 8 called Embracing Play. And we're going now to a wealthy suburb in New Jersey. It is 8:20 a.m. on a weekday, and I'm at a public school in a wealthy suburb of New Jersey. Not a single child has walked to school this morning, not even the ones who live right next door. In much of the town, there are no sidewalks. Every morning, the school's occupational therapist runs a special class for the kindergartners in the lunchroom. The gray laminate tables where the children will eat have been folded up and placed along the walls. Fluorescent lighting shines from the ceiling, mixing with the sunlight coming in through two large windows on the back wall. Long gray curtains hang on each side of the windows. The children's homeroom teacher enters the room. Her charges file in behind her one by one. Johnny walks straight as an arrow. Radhika is following him. Alexei is behind her, out of line and looking at the ceiling. Next comes Joan. She can barely lift her feet as she takes very small steps, appearing lethargic despite the fact that she's only 5 and it's first thing in the morning. On and on until 18 students have entered and taken a seat on the floor facing the therapist and teacher. The class begins. The occupational therapist tells the children they're going to learn how to crawl like a baby and walk like a bear. She asks for a volunteer to do the bear walk. Radhika's hand shoots straight up. She puts her hands to the floor, straightens her legs behind her, and moves forward without her knees touching the ground. The next 2 children are not so successful. They're uncoordinated. They don't actually have enough strength. In fact, about half the children are unable to do the bear walk. It is exactly for these reasons that the school had introduced this class a few years ago. We live in an age when many children spend much of their time playing inactively on screens and tablets. Children who play predominantly on such devices are losing touch with the spontaneous jumping, running, crawling, tree climbing, throwing, and digging that came with active play and being outside. And they might need to be taught again how to play actively with their bodies, using gross motor skills. They may also need help developing finer motor skills. Since some of these children no longer spend time outside in the sandbox, no longer picking up pieces of toys or insects or sticks and stones with their fingers and thumbs, some of them have trouble picking up their pencils and erasers. So the next morning, the occupational therapist will have them practicing picking up small balls and blocks and putting them in a cup. This is the sad state of children's play today. The transition from active outdoor and indoor play to increasingly sedentary screen-based activities is negatively affecting our children's health. Not so long ago, we equated screens with television viewing. These days, it includes time spent on computers, on tablets, smartphones, other electronic devices. Today, more than 30% of children in the United States and Canada are overweight or obese. Research has shown since the 1980s that television viewing and screen time are associated with obesity in children. According to statistics provided by the Participation Program in Canada, today, 95% of our children do not meet the daily physical activity recommendations of 60 minutes of moderate to vigorous intensity physical activity. And their parents are not exactly so much time on games rather than outside, more time sitting than walking. 5% of Canadians not get the physical activity recommendations of 150 minutes of moderate intensity physical activity per week, or 75 minutes of moderate intensity activity. It is no secret that active living is a key part of our overall health. Whether we're talking about weight loss or mobility or cardiovascular fitness or even prevention of cancers like colon cancer, the message is clear. The more we move, the better off we are. Given this basic truth, it's extremely painful to see cities, suburbs, and developments growing seemingly without awareness of the problems that will invariably encounter as a result of the inattention to how we move. By now, one of these problems should be sounding awfully familiar: an increasingly unhealthy population with ever-rising rates of non-contagious diseases like diabetes and cancers, and their risk factors like obesity and inactivity. But it doesn't stop there. When the places we live in are constructed without conscious attention to offering opportunities for physical activity, whether that's in service of getting from point A to point B, as part of recreation that's so important for physical and emotional health, or as part of recreation, we are setting ourselves up for a host of related problems. What happens to our oldest citizens when they can no longer drive themselves to stores or doctor's appointments or the homes of relatives and friends? What happens to businesses when the population can no longer easily pop in for a quick shop next door? What happens to our cities when traffic congestion is so bad that it prevents people from wanting to live or to do business there? And what happens to the environment when our overwhelming reliance on the automobile continues to wreak havoc? And yet, day after day, governments and organizations around the world continue to make urban planning choices that prioritize cars over people. So residents who want to choose a healthier lifestyle must overcome daunting obstacles or make superhuman commitments. Public funds are poured into highways and not into subway extensions or other rapid transit options. Parking lots are constructed where playgrounds and green spaces might have been created. Bike lanes are rejected in favor of road lane expansions. Suburbs continue to be designed with acre after acre of only single-family homes, situated well beyond walking distances from the nearest amenities and with no other options for people to move to as they age. But it's not too late to change. Although the negative effects of climate change are already being felt on a daily basis in the form of extreme weather events like heat waves, fires, floods, tornadoes, freak winter storms, the hope is that if we act now, we will at least be able to mitigate the severity of these events going forward. And the same is true for our health outcomes. We need to act now. We need to do what we can to ensure that people can make the lifestyle choices that will help them to stay healthy and independent for longer. We need to help people get and stay active, goals that they themselves are setting every New Year's, but usually failing miserably. But there are hopeful signs. We're seeing a growing recognition of the importance of play in our daily lives. We've seen the birth of movements dedicated to replacing our old unhealthy patterns with better ones. Smart growth, new urbanism, transit-oriented developments, active design, all are focused on finding different, healthier ways to develop and grow our cities, ways to enable us to embrace a more active and healthy lifestyle and maintain it over time. But this kind of work is not easy. However, it's not impossible. It takes a combination of vision, creativity, determination, and cooperation. Decades ago, before cars became our primary mode of transport, we were much more active. We walked, we cycled to places. Many of our jobs involved some sort of activity, not just parking ourselves in front of a computer from 9 to 5. Our kids played outside, not in front of screens, and we were healthier for it, with much slower rates of non-contagious diseases that are now running rampant. These days, it's a different story. Physical inactivity contributes to 3.2 million deaths annually around the world, 3.2 million preventable deaths. That's about a tenth of the entire population of Canada every year. Physical activity and public health experts today emphasize active living rather than intentional exercise to help people achieve the physical activity needed for health and daily life. Everyday daily transportation needs can provide the best opportunities for people to incorporate 10-minute bouts of physical activity that are optimal for health, without extra time commitments that would be needed. To go to the gym, to go for an extra run, plans that usually fail when they compete with our daily lives and the regular demands of life. If you're able to walk to work, if you're able to walk your children to school, walk to get a healthy lunch, then these minutes can easily add up, helping you get to that 150 minutes or more of moderate intensity activity per week. If you accumulate a mere 30 minutes a day every weekday, you wouldn't have to worry about that missed gym again. A 10-minute walk to school, then to work, then to lunch and back again would help you achieve 60 minutes of walking each weekday, double the physical activity recommendations for adults. For children, this type of daily walking is important to complement physical education and active play, since their activity needs are much higher, 60 minutes every day, amounting to 420 minutes a week. When it comes to promoting the notion that more transportation should be active transportation, that is walking and cycling, studies show that street and neighborhood features make huge difference. Where the choice to walk, cycle, take public transit starts and ends with recently available choices. Even the design of buildings and how they interface with streets matter. Street design features that are associated with increased physical activity include safety elements like improved lighting, projects that make safe, that work towards safe pedestrian crossings, features that calm the streets like street bumps and traffic circles, features that improve aesthetic environments for walking like improved landscaping. These features collectively can increase physical activity by a median of 35%. Community design features and policies are also important. Locating residential zones close to schools, stores, jobs, recreation facilities facilitates walking, as long as there are also safe and pleasant ways to get there. For example, effective design that connects people from their homes to nearby amenities on good sidewalks, using the shortest routes possible on gridded patterns rather than lollipop loops, good lighting, safe street crossings, nice landscaping, all will signal to a walker that the experience will be both safe and pleasant. Community scale designs and policies that improve neighborhood features have been found to improve physical activity by a median of 161%. So we've talked a little bit so far about state of children's play, how incorporating active transportation and activity into daily life is really important. We've talked about some of the features that were found from West Virginia to the suburbs of New Jersey. I want to also talk about a building project and end with a case example that I think touches on many different aspects of a healthier environment. It touches on considerations of vulnerable populations. It touches on healthy food, but also activity, also social connections. And it's also doing it in an affordable housing building in the poorest, one of the poorest areas of the United States, which is in the South Bronx, of New York City. So we wanted to end there with an excerpt there, and hopefully it serves as something inspirational. That even in something with the cost constraints of affordable housing in a very poor neighborhood, this can be done. Which means that in wealthier neighborhoods and in market rate housing, this should be doable as well. So I'm going to read this last excerpt, and then I'd like to open it up for our discussion. So this is called Arbor House, a pie in the sky idea. It's May 2012. I'm in the middle of a housing tour being arranged as part of our annual Fit City conference. I really should be paying attention to what's going on around me, but instead I'm fixated on the small package in my hands. It's full of baby bok choy, harvested and bagged that same morning. Sky vegetables, says the label, with the tagline, good for you, good for the planet. Another logo above the package's barcode reads, Pride of New York. The Sky Vegetables venture is aptly named. the epitome of health, of locally grown. The vegetables produced here are literally grown in the sky on a high-rise rooftop in the heart of New York City. When farm manager Kate Ahern had handed me with her business card, along with the bok choy, I couldn't help but marvel at the address, 1071 Tinton Avenue, Bronx, New York. The rooftop of 1071 Tinton Avenue, to be exact. It was a pie-in-the-sky idea that had taken shape and become a reality. This farm on the rooftop of Arbor House, which was an affordable housing building in the South Bronx. Stifling the desire to nibble on the bok choy right then and there, I tucked the package into my backpack and refocused my attention on Kate and her staff, who are giving us the lowdown on their work. The day before, 20 or so people had signed up for this outing during registration. Fit City, now in its 7th conference, was beginning to attract an international crowd as well as a local one. And since 2010, we had been offering site tours and field visits for interested attendees. The idea was to offer a first-hand look at some of the points of interest that our slides had already presented two-dimensionally. We had a varied group today, some from architecture firms, some from city departments, some from hospitals and healthcare, and even some guests from London in the UK. Arbor House is impressive. At the entrance, we noted the sign designating it as a non-smoking building. This offers benefit to residents who don't have to deal with secondhand smoke that would invariably seep across apartments, but also to the building owner, since smoke creates higher maintenance and insurance costs. We'd seen the building stairs, walls decorated with stenciled art, painted in bright colors, rises decked out in colorful paint, the stairwell also humming with music. We checked out the fitness room and outdoor exercise equipment like stationary bikes, ellipticals. Some of us even climbed on them to give them a try. Finally, we made our way up to Sky Vegetables, the hydroponic farm on the rooftop, where Kate Ahern had proudly handed out samples of her work. Sunlight pours in through the glass of the beautiful, extensive greenhouse, illuminating row upon row of green vegetables. In addition to the baby bok choy, there's green leaf lettuce, Boston lettuce, kale. There's a section dedicated to herbs, new plants being tended in smaller trays. And there's rainwater capture that helped to make the operation even more environmentally friendly. The South Bronx contains some of the poorest neighborhoods in both New York City and the United States, with a median annual household income of under $9,000. In contrast, a 20-minute ride on New York's subway system will take you to the Upper East Side, which has some of the wealthiest households. And affordable housing among real estate developments has some of the tightest margins for cost flexibility. To keep rental costs low, all attempts are made to also keep costs of construction and maintenance as low as possible. Therefore, unlike market rate housing or purchased housing that can raise its prices in construction and maintenance costs, if construction and maintenance costs run over, there's less room for dealing with increased costs and budgets in affordable housing. Arbor House was already a work in progress when the Bloomberg administration made its commitment to building or preserving 165,000 units of affordable housing. With its prediction of significant population growth for the city. Ever striving for efficiency, the Bloomberg administration figured that if it was going to be creating new housing, they should be creating it in a way that would help to address some of our priorities. Environmental concerns were high on that list. And so new housing, like other construction, needed to be green, particularly was involved. Health concerns over high rates of chronic diseases, of obesity, were also a priority. So these presented opportunities. In this context, that I'd come to know our house's owner. Soon after our first lead for physical activity with design teams that helped with our own projects like the Riverside Health Center for another affordable housing project called Via Verde. New York City staff and myself also met with Les Bluestone of the Blue Sea Development Company, and shared some ideas. Les wasn't at all deterred by the fact that Arbor House was already in the late stages of architectural design. He simply asked his architect to take another look and see what could be done. At our second meeting, perhaps a month or two later, Les proudly and excitedly presented us with a revised design showing that he had moved the main entrance of the lobby moved the main entrance to a different side of the building so that it would open onto a lobby where the stairs were located rather than the elevator. So this should help to promote stair use, right? He asked. But Les had additional surprises up his sleeve. He'd had his landscape architect redesign the building's courtyard to incorporate exercise and play equipment throughout. Under the new design, the courtyard resembled a hybrid circuit training course with art elements incorporated. Les turned his community room into a gym with a children's climbing wall, exercise bikes with video games on their monitors to entice teens. He transformed his rooftop into that hydroponic farm, the first of its kind in a residential building in the United States. Sky Vegetables would supply a percentage of the vegetables produced to building residents and sell the rest to New York City restaurants and chefs keen on sourcing their food locally. Money from the sales would help to support the cost of the farm. In 2013, Arbor House opened its doors, and the response was overwhelmingly positive. In addition to being platinum certified by LEED, Arbor House was recognized by the American Cancer Society as a healthy high-rise for its completely smoke-free status. Perhaps the most important accolades, though, came from the building residents. In a Time magazine article one of the residents spoke about the building's amenities and family. He'd never exercised as a kid, he admitted, but he believes that Arbor House is setting his kids up for a lifetime of better health. This will make it second nature for them to be healthy, he told Time. It won't be foreign to them like it was for me. And I'm going to stop there and perhaps open it up for discussions. I don't know if folks here, if anyone's read the book yet, but if you do, feel free as well to chime in and add your thoughts.
Okay, everybody is set for mute right now. Do you want me to allow everyone to talk, or?
Yeah, I think so. I think, I think that would be great to open it up.
For you.
Thank you, Jonathan.
Hello. Hello.
Hello.
Hi, this is Kathy Lewis. I've enjoyed your talk very much. My question tonight is, how does your work compare with the work that's being done by the Blue Zone people?
Yes, I'm aware of the Blue Zone's book. I've read the book. My understanding is that, so my work and our work now is, for example, funded by a grant. And so my understanding is that with the Blue Zone's work, cities that are interested in undertaking Blue Zones do pay a fee for the consultation by the Blue Zones team. With respect to our work currently, for example, in Housing for Health, we are funded, our team is funded by a 5-year grant by the Public Health Agency of Canada. And because of that, we are able to use that grant to hire staff and researchers to help support communities and community staff who are interested in this work. And currently, under the grant, we haven't needed to charge fees for that kind of assistance. I would also say that a big part of how we do our work is we coordinate multiple municipalities and multiple communities that are interested in this work to work together. And so we actually are learning from each other, not just from a consultation team, for example. So yeah, and the work that I did in the United States was quite similar. So we got grants from the US CDC and from different foundations to help us do the work in New York. But then we also got a mentoring grant from the US CDC where we mentored 15 US cities to work together on learning from each other, how to improve our policies. So Kathy, I don't know if that answers your question.
It's an interesting answer. I'm just feeling that I am a community member who is interested in a healthier community.
Mm-hmm.
I live in Lethbridge and have lived here a long time. What is attractive to me about the Blue Zones is that it is very comprehensive, and it seems to me that it's very, very aggressive in that it includes, and it actually dictates that all sectors must be involved.
Mm-hmm.
Must be involved before they'll work with the community. So I find that quite attractive, because I think maybe that's sometimes what we lack in our world is that commitment. Given the money that we put into health care or illness care, I guess I'll call it, we put by comparison very little into prevention. And I applaud all that you're doing. And if you have ideas on how we can access funding for any project that would increase the health of our community, that would be great. But thank you very much.
Thanks, Kathy. I want to mention that the Airdrie Blue Zones project folks have also joined our Housing for Health partnership. So I think that if a community can afford those extra consultation dollars, yeah, that's fine. But I think what we're trying to do is to create a platform where even if a community says, hey, we can't afford to pay Blue Zones to help us with this work on a one-on-one basis, I think that there are opportunities now for those communities to also join this Housing for Health project where, that doesn't require that. But yes, in our Housing for Health project, as with what you've mentioned, Kathy, having multiple sectors involved is critical, right? Clearly, folks in the health sector often are, especially folks involved in this kind of work, whether it's in healthy food environments or healthy built environments, they're aware of the evidence that they bring to the table around the links between those community factors and health. But in order to enact those community factors and integrate them into community planning, you need urban planners, you need architects, you need different departments of municipalities. And in fact, for example, in the Housing for Health project, we've got those different groups involved. And I'll stop because I think Marcia has a question.
Oh, no, I'm sorry. I didn't mean to raise my hand. I was listening carefully. It's very good.
Oh, okay. Maybe, Marcia, you had unmuted and that's why you showed up on the screen. Yeah. I think if you
I got a message on the screen saying I was asked.
Yeah.
I'll just comment though that it's interesting to hear the questions that are coming forth, because I'm actually, even though I've been doing some of this work in Medicine Hat for a while, I'm not aware of all these things as I should be. So this is really good.
It's wonderful, Marcia, that you're working in Medicine Hat. Are you with the city?
No, I'm actually I'm the counterpart for Heather in the public department.
Oh, wonderful.
Nutrition, yeah.
Do you know, because one of the, I don't know if he's still the city manager, but the previous, the city manager for Medicine Hat, I can't remember his last name, his first name is Kent. He had actually come, when I was in New York, and I still teach this course, annually for Columbia University. So every year in June, there's a course called Designing Healthy Cities. We didn't have it this past year, like this year, but usually annually in June, I teach a course called Designing Healthy Cities. And different sectors of professionals come to take that course. And so the Medicine Hat, City of Medicine Hat city manager had come to take the course a few years ago when I was teaching it, called Designing Healthy Cities. So maybe interesting, Marcia, if you're interested, for us to continue these conversations after tonight to see if there's opportunities to loop Kent back into, if you're not already working with him.
Well, I was going to ask, did you not come to Medicine Hat a few years ago?
Yes.
Yeah, I was at that. Yes. I thought you had been here because there was a lot of us from the community at that workshop that you were here for the full day for. So
yeah. Do you know what happened there?
It's a little
that
bit
was when Jim.
strange.
Yeah. Jim Talbot,
Go ahead.
the previous chief medical officer, so in the prior administration, had actually asked if I would start this process. And we had done workshops in Edmonton, in Calgary, and in Medicine Hat to start to stimulate those intersectoral conversations. And then, of course, administration changed, Marcia, and then, or this was two administrations, was this 2 administrations ago? Anyways, administration changed. I think it was 2 administrations ago. And then subsequently, the conversation stopped. But I think, you know, is this work continuing, Marcia? In Lethbridge?
Well, that's what's
Medicine
strange
Hat?
about it. It really, I would say, sorry, can you hear me? No?
Yep.
You're not hearing me? Okay. Sorry. Oh, yeah, okay. I would say yes and no. There is not a public or not a community-wide movement that is occurring, but the city does have some of its own initiatives that it's working on in the active living area. Health, natural playgrounds, for example. But there is others, like we have a healthy communities movement, but the city is somewhat involved, but they're definitely not really super engaged. They're kind of doing their own thing a little bit. Like the staff at the front lines participate, but we haven't had a lot of collaboration at the higher sort of higher levels in recent years. And it might be due to also changes that have occurred in the community and with Alberta Health Services and the way, you know, our leaderships and our structures have changed too in the past 10 years. So we don't have the same structures to collaborate. So part of it, I'm trying to, I don't know how to explain it in a very short few words, but we do have some things going on, but it's not at the level where I had expected us to be going after we had that workshop when you were here. Yeah. So I've been trying to understand what happened. So I appreciate you sharing that with me, because yeah.
Well, if you're interested, you know, maybe we can follow up with a meeting with you and members of our team, and we can have a conversation about like what's happened and whether there are any next steps. Maybe as part of this Housing for Health as well, we could, you know, pull the different players in.
Yeah.
Because, you know, we have a lot of municipalities.
Yeah, that would be good.
In the Housing for Health, yeah. Not just in the Edmonton region, but we've got like Whitecourt, we now have Lethbridge, we've got like Wood Buffalo up north. We've even got we've even got interest from, you know, some of the planning sector in like Saskatchewan and possibly Manitoba and Ontario also going forward. So, okay, thank you, Marcia.
Yeah, I think it'd be great. Yeah, thank you. We will follow up then. I appreciate that. Yeah.
Please do.
Dr.
Yes.
Lee, it's Heather. I have a question. Just you brought it up a couple times, the amount of funding, there's not a lot of funding for prevention. Like even, I know our former medical officer of health, Dr. Hasselbach, he's retired now from British Columbia. He talked about 3% of the health budget going towards public health, but really only 1% of that budget goes for prevention. The 2% is more immunization, that kind of stuff, which is important, but there isn't a lot of funding for this. Like, it's great that you got this funding from the Public Health Agency of Canada, but where does that come from? How do we capture some of that?
Yeah, I think, well, a couple of things, right? I think you're absolutely right. I think the prevention side of work is way underfunded. I think part of what we're hoping to do is to use things like grants to demonstrate the importance of sort of recreating successful initiatives that have been done elsewhere in the local context. But I think what we need is also an engagement that, you know, grants end, but grants should translate, if it's successful, the initiative should translate into permanently funded interventions. I'll give you an example. It's discussed in the book. You know, one of the initiatives that I was in charge of in New York was an initiative called FRESH, which was Food Retail Expansion to Support Health. So what happened was, like, the health department worked very closely with the city planning and with economic development. And we actually mapped out the neighborhoods that had the highest rates of obesity and diabetes and, you know, poor eating. And lo and behold, of course, it overlaid completely with the neighborhoods that lacked supermarkets. And so the food deserts. And so what we did was we worked with city planning to create some zoning incentives. So one of the zoning incentives was, you know, actually downsizing the definition of a supermarket in zoning so that it didn't have to be like a 40,000 square foot store. You could have a 10,000 square foot store with minimal parking if it was located in the in-town areas, right? Which many of the impoverished neighborhoods were. We worked with economic development, and they were able to actually negotiate with New York State to forgive and forgo taxes on construction materials for supermarkets that were willing to either expand or newly create supermarket operators or newly create supermarkets in these food desert neighborhoods. Then what happened was economic development said to us, you know, we're really concerned that, you know, we've put all these efforts into these incentives, like the zoning incentives, the tax incentives, but in fact, supermarket operators may not use them because they're new, they won't really know how to navigate those incentives. So we really need like a fresh coordinator who would function as, you know, an outreach person to the supermarkets, but also the supermarkets that are interested in these new incentives could actually work with that person to navigate the system. So what we did was, there was a health grant, a New York State Health Department grant that had just issued a call for proposals at the time. So we rapidly wrote, the health department, my team rapidly wrote that grant proposal, and we got enough money to get a coordinator for 5 years. And what was interesting was at the end, and we, you know, talked to planning and city planning and economic development, and we said, well, where should this coordinator sit? Should they sit in health? And the consensus was that no, they should sit in economic development, because if a supermarket operator is interested in using these tax and zoning incentives to create a new supermarket, they'd most likely be working with and through economic development. So we actually took this position and sat the person in economic development. And 4 years later, when we had, in the last year of funding, economic development was like, oh my gosh, this is gonna end. This grant's gonna end, isn't it? In like a year's time. And we're like, yeah, and there's no replacement for this grant. So economic development actually, because this person had become a part of the economic development team. And by that point, you know, quite a number of supermarkets had been created. And it created not only supermarkets that produced, defined a minimum defined area of produce in those food premises, but those supermarkets had created thousands of jobs several years later. And so economic development was able to get basically the city administration to agree to a permanent full-time position for the supermarket fresh coordinator position to be a permanent position in economic development. So I think what we should be aiming to do, frankly, is using grants to demonstrate concept, but then if we can demonstrate success, there has to be this conversation as to how we translate some of that success into permanent funding that supports the infrastructure needed. The other thing I wanted to say, though, is, a lot of policy things, and this is why policy things are so important, but in order to do policy, you actually need staff who are, working and connecting different sectors. But policy interventions are cheap, right? Once you've actually passed a new policy, the reality is, even if it's a new regulation, the majority of people or businesses who have to adhere to legislation, they'll comply. Now, that doesn't mean that you don't still need some enforcement for the few that don't comply, right? Because if you don't have that enforcement, the non-compliance will grow. But if you have that enforcement, the reality is that most businesses and organizations comply with the law. And so changing the law is actually a very cheap way. You do some upfront investment, usually with staffing, you change the law, and then when the law is changed, it usually is permanent and very long-standing. That's the same also with infrastructure interventions, right? Environmental interventions is so important because once it's changed, it's there for a long time. And one of the things I heard a lot of when I was working in a place like New York was a lot of architects, planners, developers will say, oh, yeah, because we thought of this ahead of time, we could just incorporate it right into our designs from the get-go. And so, for affordable housing, for example, we actually published a document for folks who are interested in some of these documents. I've collated some of them, a lot of them on my website. So just www.drkarenlee.com. You go to the resources page, and there's a document there called Affordable Designs for Affordable Housing, where we looked at affordable housing designs in New York, San Antonio, Texas, and Atlanta, Georgia. And we found that you could integrate in a lot of healthy elements without additional costs. There were a lot of elements that could be cost neutral or minimally increased by integrating these elements. So I think there's a lot of things that we can do with some investment that, if we do it well, the costs don't have to be, they don't have to be huge. And often it's upfront, and then the benefits are either permanent or long-term. So this notion that we should be thinking about how we design our communities, our buildings, whether that's our food environments or our activity environments, if we can integrate them from the get-go and how we think about our communities, they don't have to cost a lot. The other thing as well is, I think, the reality is, one of the things as to why other sectors, I think sometimes we hear comments like, hey, health isn't really, health isn't really the responsibility of people outside of health care. And while that may have some truth, the reality is we know that the work of professionals outside of health care really fundamentally determines how healthy our communities are. And even though these sectors might say, hey, it's not our job, our job. Health is not our job. The reality is that healthcare budget in every province is up an ever larger portion for infrastructure, for transportation, for creating housing, for education. And so in some ways it is kind of the job. It is important for all these other sectors to recognize that if they don't work with health to improve the healthiness of our communities, then the healthcare budget will increasingly take over the total budgets. So I don't know if that answers your question, Heather.
No, I think that's great. Yeah, I think it's, selling people on this too, just with what you just said, whose responsibility is it? So, and
I would say
I
it's
think
all our responsibilities, right? We don't say, for example, that we should have no clean water infrastructure, no sewage infrastructure. And yet who builds that infrastructure? It's not healthcare, right? It's infrastructure.
Yeah.
So,
well, and I think it's trying to convince these new communities too, like, high school goes up, fast food restaurant goes close to it, or one of the convenience stores, and it's there for years to come, but somehow trying to prevent that from happening, because it's decades of unhealthy food choices close to teenagers who, if that's close to them, that's more likely what they're going to choose.
Well, that's the hope too, right, Heather, is that some of the examples in the book could serve as, this isn't, if you wanted to do something good around increasing the healthiness of your community, it's not something that's new. There are a lot of jurisdictions from around the world with very innovative ideas that we can adopt and adapt now, right? Like Detroit, has a rule where you can't have fast food in the immediate vicinity of schools. And, so it's not a new idea for us to do that. So, I think learning from other jurisdictions and examples that, I've tried to document in the book is actually really important, because we don't have to come up with these ideas anew. There are jurisdictions that have already done them. We can learn from them. We can get ideas from, jurisdictions around the world. We live in a global world, but you're right. I mean, it's not, there are challenges trying to convince different sectors, but, you'll be amazed. I think that, there are often early adopters in every sector, or at least some sectors in each community. Even if others aren't open at the start, there are some early adopting sectors, and you can always work with them to start to make progress and to demonstrate success. And then, when you demonstrate success, other people often want to jump on board. But that also speaks to the importance of things like evaluations of health and co-beneficial outcomes, right? It's important to do that because you want to demonstrate and formally document some of those outcomes when you're doing innovative projects.
Hi, Karen.
Hi, Rose.
Hi, it's me. I read your book, and I think sort of you alluded to it, like the benefits of access to healthy vegetables and fruits and a grocery store nearby. But how important is mental health, like homelessness, addictions, having more supportive housing, not necessarily in the downtown core, but just within walking distance of a grocery store, walking distance to a gym, walking distance to their support workers. I work in mental health housing, and we're one of our first Homes First providers, but we're based in Toronto in 1979 or 77.
Oh,
so we're with housing community. I'm with housing community homes, and how important is mental health? Is if it's cities, because I know you sort of allude to it, but you don't say it. Like mental health with physical fitness as well as food security and housing and transportation? How important is mental health in a city?
Yeah,
Or is
really
that all
important.
related, or the result or the outcome of it?
Yeah, I'm really glad you're pointing this out, because I think often we think that, physical environments and physical risk factors like physical activity are related to physical health. And then things like social aspects of life, like social isolation, must be connected to the mental health aspects of life and of health. And in fact, of course, things like physical activity are connected to physical health, and social isolation and social factors are connected to mental health. But in fact, studies show us that the connections are also in the other way. So for example, more and more studies are showing the importance of regular physical activity in protecting mental health. There are now studies that show that regular physical activity can actually be as good as antidepressants for mild and moderate depression, right? And we know that physical activity is associated with better mental health. And so all of those physical environmental things that would promote more walking and cycling and physical activity would be expected to promote mental health as well. Similarly, social isolation. There are studies that show that being socially isolated isn't just bad for your mental health. It can actually be very bad for your physical health. So there's one study I'm aware of that, looked at social isolation and risk of getting a first heart attack. And they found that people who were socially isolated were 50% more likely to get a first than people who don't. And so the mental effects, you're absolutely right. It's also pointed out how elements, right? So there's the active living, healthy eating, social connections pieces, but additional services like being able to access mental health services or other healthcare services. If you can't necessarily drive, can you access them by public transport, by walking and cycling? Those are additionally important parameters as well. So thank you, Rose. Others?
Thanks, Karen. Yeah.
Yeah,
Thanks,
thank
Karen.
you. Are there others who have any thoughts? Are there others who have read excerpts or parts of the book and have any sort of feedback or thoughts on it?
Well,
So
oh,
if there's nobody else asking, it's Marcy, I would ask another question, but if there's others in line, I'll let them go.
I think you should go ahead, Marcia, because I think folks are, they seem, I think you're good to go.
Okay.
So,
well, it sort of relates to the question that was just asked. So, that's what was on my mind as well. But also in the context of things like our community recently got quite involved in poverty reduction. And that was what the city was quite focused on for a couple of years. And it's now kind of been turned over to a council or a committee that's supposed to be leading this. Mm-hmm. And then there is another group of us that are focused on built environments and social environments and healthy eating and so on. Mm-hmm. So where I'm trying to ask is, have you seen examples, or from the things that you've learned, can you comment on how we can help people buy in? People seem to not always just make the link. Like, they're not always making the link between addictions. We have a high suicide rate here recently. In Medicine Hat, we've had 6 suicides in the last 6 months. So it's on people's mind. And then we look at poverty issues that were already a problem and now will be greater. And as well as all of the usual nutrition and active living things. So I guess it seems to me that in a large city, they have a different kind of infrastructure. In small cities like we do, it's you're kind of talking to the same people all the time, and you can't segregate out so the issues, because those same people would be going to 10 different tables to have a conversation, because it's all the same people in every kind of you know sort of decision making position, and whether it's the city or health or business and so on. It's a smaller community of people. I think that we really need to be able to help people not work on one issue, but work on the issues collectively, is sort of what I see, because otherwise we have too many issues and people get too diluted. There isn't enough people to go around to give each issue its own attention and focus. And since they're all interconnected, it really seems to me that we kind of need to learn how to connect the dots so that we can, you know, put that energy into a more coordinated, collaborative effort that benefits all of these things.
I totally agree with you, Marsha. I think even in bigger cities, right, the reality is, you know, I think this is where addressing the upstream determinants of health is so important, because I think when you address those determinants, you can make an impact on so many outcomes. So for example, if you were to create healthier communities that had different types of housing, you know, that often gives you sufficient density then to have the mixed land use. But the mixed land use and, you know, connecting housing to different types of amenities can functionally create walkability in that community. Now, we know that walkability enhances walking and physical activity, but it can also decrease things like air pollution if people aren't driving as much. And it can also, but it's also been shown actually in studies that secondary benefits to walkability include decreased crime, because you get more eyes on the street, increased social connections and decreased social isolation, because people walking around in their neighborhood are running into each other. It increases, so it can increase safety, it can decrease social isolation. You know, it actually has been shown to boost retail sales, so that's good for the economic health of that community. You know, I mentioned the Fresh initiative where we were working with city planning and economic development. Now, economic development didn't come on board because we were going to improve health. They came on board because they were concerned about those food desert neighborhoods that were impoverished. And by working together to create more supermarkets, that was creating more jobs and employment in those neighborhoods as well. So I totally agree with you that I think we need to look at what are all of the myriad of benefits that we can create when we work together to address upstream determinants of health, whether that's built environment, social environments, including income-related issues. I was going to make a comment about poverty reduction. I think, you know, we know that poverty is associated with poor health, but I think we also know that income inequality is associated with poor health. And I think one of the things we also have to frame around the economic discussions on health is not just poverty, because I think, although that's important, framing the whole economic discussion around health on just poverty, I think, potentially makes people who are not impoverished, like the middle class, less interested. But I think if we can include in those economic discussions economic inequality and income inequality, I think there's many people in the middle class who know that their incomes are being eroded and that income inequality is growing And I think we can pull them into the discussions if we were to frame our discussions more concertedly to include income inequality issues and the growing income inequality that we're seeing in Canada and in many parts of the world. I don't know if that helps at all, those comments.
I think that that's a really good point of how to frame these things. So I think that's really really valuable. I was also, I think, drawing, if I just want to clarify if I heard you correctly, I think what you were saying is that you may not have directly said this, but what I took was that there are certain key strategies that can be undertaken that will have many benefits, and so it's not so much that we have to be doing 100 strategies at the same time. We can choose a few of those key things which we can then try to communicate to get this collaboration and buy-in. We help people understand that how broad-reaching the impacts are of these key strategies.
Yes.
And it sounds like one of these key strategies is the neighborhoods, and the walkability is kind of what you were driving at. Is that what I was hearing?
Yeah, that was one example, right, of how when we create a healthier neighborhood or even healthier food environments by creating more supermarkets and food deserts that are frequently, impoverished neighborhoods, we're creating jobs at the same time. We're, by improving walkability, we're boosting retail sales at the same time. And so I think it's really important for us to not frame like this strategy leads to one outcome. Rather, we're very efficient. This one strategy is going to give us all these priority outcomes: health, environment, economic health, and the health of our businesses and local businesses. Just so like creating employment, like just so many different things we can achieve. And if we do that, I think we can also bring enough stakeholders on board to support these policies going forward, because different sectors have different priorities. But if we have multiple outcomes we're trying to achieve with them, hopefully we can bring multiple sectors on board. And it's also, something to say to politicians, right? Like, do this thing because you could achieve so many priority outcomes for our community.
Yeah, have you written any? I know at one time the cities and the municipalities, they get certain influences to my and I know one of the magazines they read is Municipal Issues. And I wondered have you ever tried writing an article for these that goes out to a lot of the
I've written for planning,
municipalities?
for example. I've written for planning magazines like Plan Canada. Its centennial issue in 2018. There were 2 health articles, one on its history and one on what should we be doing going forward. And I was asked to write the going forward article. So this circulation apparently reaches over 7,000 planning professionals in Canada. But if there are other thoughts, like what is this called? The Municipal Policies? Is that what it's called? The magazine that you were talking about?
I think it's called Municipal Issues.
Municipal Issues?
Yeah, Municipal Issues. I have a copy of it.
Yeah. Maybe.
Yeah, from years ago, a copy was shared.
Yeah. No, I haven't written for municipal
Wondered
issues.
if you knew what.
Yeah, but we would be happy to take a look at writing an article for it. But we would be happy to. Maybe it could even.
I'll dig out the information for it.
Yeah, sounds good. I don't know if others have questions.
Track that down.
Okay, sure. Yeah. Do send us a list, and others here, if you have thoughts on, targeted publications that could reach different stakeholder audiences that you might work with, do let us know, because we'd be happy to write excerpts for it. I was going to say that Melissa had something that she wrote in the chat box. And I'm just going to read it to the group. Hi, Dr. Lee. Have you ever worked with small, rural, remote communities? And if so, were there any big differences between city and small towns when trying to implement and encourage change? I have not read the book yet, so I apologize if you discuss it. We discussed some of it. I was going to say that, yes, I have worked with smaller areas. So, the mentoring initiative that was funded by CDC in the US, I'd mentioned that we had 15 US communities join that mentoring effort. And we were frankly really shocked when we saw who signed up for the mentoring, the peer mentoring with New York City. So we had large cities like Chicago, Boston, Philadelphia, but we also had like really tiny places. Like we had a small tribal nation in Oklahoma who signed up. We had counties that had, more rural or unincorporated areas. And I think what we were able to show through that initiative was that you can do something to make progress in your community. Now, it's at different scales. The initiatives might be slightly different. So I'll give you an example. That small tribal nation that was in Oklahoma, what they chose to focus their initiatives on was to use their school as a hub for both active recreation and active transportation. So walkability around the school, but then using it also as a hub for active recreation amenities. So I think there are different scales that we can do this work in. And, the different scales in different communities might have different foci, but it doesn't mean that we can't make progress on these fronts of active transportation, active recreation, healthy food and beverage access, and also social connections. Don't know if that answers your question, Melissa. Okay, great. Are there other comments or questions from folks? There are lots of folks who are on, but kind of quiet. For those who haven't spoken, I'm just wondering, what organizations do folks work for? Are folks from Lethbridge? Do you have any sort of thoughts based on your area of work, or any volunteer activities as a citizen that you might want to share?
I'm from Toronto, as you know, Karen, and I work in mental health. I work in a drop-in setting. So I work for a housing provider for people who have mental health and addictions issues. So a vast majority of our clients or our participants are also coming of age. So I was wondering if you could touch upon like the boomers, like what's happening to them, what's going on with now with the epidemic of COVID, and how nursing homes are very dangerous places to live in because of the cross-contamination, and how the aging are now going to be supported, like our generation, what's going to happen to us in terms of like.
It's been really interesting. It's been really interesting because, I've had discussions with some of our AHS physicians, and, those who are working with seniors, they're finding that, for example, because of social isolation and lack of physical activity amongst some of their patients, people are going from healthy, strong senior to frail elderly during this COVID pandemic, right? And part of that comes from the fact that people are socially isolated, like I said, and they're physically inactive. And so there are, so I think even in sort of this age of COVID, what we're going to do to keep people moving, eating healthily, and socially connected is absolutely important. And I think there's two implications for us in this realm. One is, there are communities now, including City of Edmonton, for example, that have been doing a lot of shared streets, closing off like where there are multiple lanes for cars, closing off, a lane so that those lanes could be used for walking and cycling instead of crowding on the sidewalk. There are more shared streets. So initiatives like these can really help, I think, during these times of pandemics, because it can help people to have a physically distant space that they can go out to, and yet in these physically distant spaces remain socially connected. But I think it also speaks to, in the future, when we're actually building new communities, when we're actually renovating old communities, there are some infrastructure implications, I think, from pandemics like COVID, where, we think about, in the past, we might say, hey, have complete streets where you have sidewalks for pedestrians. Hey, have benches where seniors can sit along their path so that they can go for a walk, but have places of rest and respite. But now I think there's how do we do that going forward? Do we need to think about the designs of these infrastructures as well, and specifications that can, if we have future pandemics like COVID, can support people to be active, to eat healthily, to access the amenities that they need, to be socially connected and yet physically distant. So examples would be, how wide should our sidewalks and paths be going forward? If we have benches along the way, how should they be designed? And how should they be spaced? Issues like that, I think, play a role. So thank you. Other comments or questions?
Hi, thank you so much for that talk. I really, really enjoyed it. My name is Nikki. I recently graduated from the U of A, actually, with a master's.
Congratulations.
Thank you.
A master's in?
Ecology.
Ecology, okay.
Yeah. And I just started an internship in municipal or local government.
Oh, where?
For the county of Werner, so south of Lethbridge.
Okay.
Yeah, so a little bit different. But talking about innovation and I guess kind of future planning, I was wondering if you have any, I guess, vision of how technology might be incorporated into fit cities, the way they've talked about smart cities. People have Fitbits. They're being told how many calories they eat and how much they walk, and how planners and municipal government might incorporate that into everything.
I think we have a lot more technology now at the individual level. And yes, how can we harness some of that individual level data? But I think, as part of municipalities or organizations that create infrastructure, we, I think, could be thinking also about how to better integrate these technologies right into community infrastructures. For example, if you're building a new path or trail, why are we not putting in some counters, right? Like laser beam counters as an example, that could let us, track use of the trail, or segments of the trails that might be more popular versus underutilized. So I think that there's technologies that can be incorporated in for tracking and monitoring of use, and therefore also potential, health and other outcomes. There are technologies that can be incorporated, I think, to prompt people to better behaviors. So here's an example. Many times if there's cities that have an LRT like Edmonton, right? You don't know when the next LRT is until you go down to the platform, like when the next train is. But, if we were to actually have some of this information out on the streets, coupled with messaging like, next train, 10 minutes, next station, 5-minute walk, plus X number of calories burned, right? I think that we could there's good evidence that point of decision information that prompt healthier behaviors are effective in getting people to change their behaviors. So, information that we read like on the web, or in a textbook, or in a paper months ago, they're much less likely to actually to end up in behavior change than information that we put at points of decision. Like you post calories on a menu board, and it's much more likely to be used and be effective in changing people's behaviors and what they buy than if they've read about those calories on a website 3 months ago. Similarly, there are technologies like that can prompt people to use the stairs more than the elevators. And you can use technology to do that, like on information boards, etc. And so the example that I gave was stair use, but also, like I said, like where we place information, like the next bus and the next transit, could, coupled with encouraging and directly encouraging people to take some healthy behaviors, like, walk an extra stop, etc., I think could also be utilized more concertedly in our infrastructure. I don't know if you have any thoughts on that.
No, I think that makes a lot of sense. Personally, living in Edmonton, I used a lot of Google Maps, and the fact that ETS was very well integrated, letting me know like the next bus is coming at this point, making that decision on I'm going to walk another stop or I'm going to wait. And I never felt like I needed a car because I had access to that information so quickly and so easily. Really made a huge difference. And I am excited to see where it goes.
Yeah, I think that when we rely only on people's individual devices, though, then equity issues come into play. So, for example, if you don't have a Fitbit, if you don't have an Apple Watch, if you don't have a smartphone, then, you're left standing at the bus stop not knowing when the next bus comes. And so there is something true said about community investments in, like, investing in technological infrastructure that goes directly into the physical environment for everyone to access, regardless of whether they can afford a Fitbit or a smartphone or not.
Right.
Yeah.
Definitely. That makes sense. Thank you so much.
Yeah, thank you. Others? We also hope that some of you will contact us at h4h@ualberta.ca if you want to join the partnership working group. We have currently a Healthy Community Guidelines subcommittee of this working group. So we're working with 2 pilot developments, an infill in Edmonton and a greenfield development in Whitecourt, so bigger city, smaller town. And we are, through that process, created a list of like strategies at the building, site, and neighborhood scale that we put together for the development teams in these 2 projects. And as it turns out, this list of strategies, a whole host of municipalities and also AHS folks, some of them are here, who've heard about it, have become interested in potentially using these in their future projects. And so if anyone here is interested in that, please contact us, and we'd love to have you join this process. The larger partnership working group only meets 2 or 3 times a year to get updates, to network with other partners, and we've got at this point over 100 partners on the partner list. And then for others as well, can I just also mention this? The people are buying the books and not necessarily writing reviews. And sometimes I'll get people sending me their individual thoughts and not necessarily writing reviews wherever they're purchasing. And so I would encourage you, if you get a chance to read the book, please write a review on wherever you buy it, like whether it's Amazon or Indigo or whatever, or your local bookstore may have a website for reviews as well. So I was asked to remind folks of that. Other thoughts or comments? people getting tired. I see Robin has written something, so I'm going to make a comment. I'm going to read Robin's comments. Robin said, she's with Chinook Primary Care Network. I work with clinics to provide patients with chronic disease management education. Great new study out of U of C that we are participating in, providing healthy food to diabetics experiencing food insecurity. Thank you for sharing that, Robin. I wanted to mention that I think that there's a lot more room for people who work with patients on chronic disease prevention and management to also work with public health professionals like myself and some of the other folks here like Heather and Melissa who you know, I think what we would love to do, I would love to hear from you guys about some of the challenges that your patients might be facing. And I think that we could work concertedly to see if we could, you know, for example, if we could play a role in creating community images. So if you're hearing, for example, from a lot of your patients, they just can't buy food in a particular, there's the opportunity, I think, to with the public folks who are doing this sort of work on healthy communities in that community to try to bring maybe a new supermarket or farmer's market. And then in turn, we could probably really use your help if we were able to move that to a city council hearing, for example, have you guys speak for and advocate for improved policy issues that we could help to coordinate. So I don't know if you have any thoughts on that, Robin, or others. And I probably shouldn't speak for oh, wonderful. Robin's already on the board of Healthy Lethbridge. Terrific. So you guys are doing that there in Lethbridge. Wonderful. Other comments or questions? Trish, do you have anything to say as our sort of moderator and Jonathan as our host? Are you guys still there?
Yeah, I'm still here. I just wanted to say thank you so much for all the information tonight. It's been really informative for me, so for somebody who's not in a health profession at all and working at the library. So, yeah.
Just so you know as well, Jonathan, like from a library perspective, you know, in Edmonton, under the Housing for Health project, one key piece. So we've got pilot developments, we've got to learn directly from them. We've got policy pieces, partnership pieces. Just so everyone knows as well, we are planning to have our first Fit Cities, Fit Towns Alberta conference, modeled after the New York City Fit City conference that I told you about in the book, in February of this year. If we're lucky enough for the pandemic to be done sufficiently that we can have a conference in person, then it will be in person in Edmonton. If not, then we are planning a virtual conference. So if folks are interested in that, please do let me know. And the other element, Jonathan, that I wanted to let you know about is we have also a community engagement component where we're actually working with groups like organizations and community groups that work with community residents to run workshops, like healthy community workshops that are meant to engage community members on these issues, to inform them. But then our workshops are often structured such that we work closely with the residents of a particular community or neighborhood, and we actually work with them to brainstorm ideas that they could potentially implement to make their communities healthier. So some of the types of ideas that have come up include, you know, we've got this piece of vacant land. Why don't we change that to a community garden? Or maybe we can do a pop-up play space over the summer. Maybe we could do some street closures to cars on some weekends in the summer or even in the winter, and use as a space for children and community members to come and play. So play streets, the idea of play streets and open streets and summer streets. Some of those ideas are also in the book. So Jonathan, just to let you know, if you wanted to do something in follow-up that may function like a community engagement workshop in partnership with the public library, maybe that's something that we could consider as well.
I think it's something we could definitely touch base with afterwards. I think it would be a good follow-up and fit in with what the library is trying to do. So yeah.
Yeah, because we've got grant dollars. Our grant dollars support that as well. So there are potential opportunities for doing that as well, and without to necessarily cost to the organization that's interested in this.
Okay, that's fantastic.
Hello, Dr. Lee. Oh my gosh, this has just been so enjoyable, and I've really appreciated all the questions and the perspective from this bigger viewpoint. And it makes me realize, you know, we're really fortunate here in Lethbridge. We have all these wonderful walking trails that connect all of our communities. I'm a runner, and you know, I can run from one community to my next neighborhood and run through beautiful green spaces. And there's like the little benches that you talk about for the seniors to rest at. And yeah, so I feel like, you know, you're reiterating why it's important for us to keep striving to get better and what else can we do here in Lethbridge. I guess my biggest concern with all the work that I've done with Heart and Stroke over the last 7 years here through all of the communities in Southern Alberta, from the Crow's Nest Pass through to Medicine Hat and even to Warner, Nikki. I've worked in Warner and I love that little community. I feel like one of the things that I notice is, and that's important to me, is equality for all children, no matter socioeconomic status, to have these equal opportunities for health and fitness. And so one of the questions I feel like is, what inspired you, Dr. Lee, to get involved with this work? Like, what was it that was the impetus for you that you thought, I've got to, and with the work that you're doing presently, with this new project. So you obviously have a great care for those that are maybe less privileged or less fortunate. How can we uplift them, help them, give them the same opportunities? So what was it was it from your upbringing, or what was it that really inspired you to want to pursue and help us all, you know, lift others and make it possible for all to have great health as best as possible?
You know, it's so interesting because I think I've always been interested in like social justice issues when I was growing up. And, you know, when I discovered public health, it was like, I just loved it. And like many other people, I think, you know, probably various people who are here from public health have different stories. But for me, I discovered it like by accident. It was like serendipitous, right? I was in med school, and we were encouraged to do electives between our second and third year. And I didn't know what I wanted to do. And so I went to the electives catalog thinking, someone had told me about radiation oncology. And I thought, well, maybe I'll check that out, because, you know, there's certain specialties like radiation oncology that you're not going to get a chance to see in your regular internship in med school. And so usually it's things like, you know, you'll see family med, general surgery, emergency medicine, pediatrics, gynecology, obstetrics and gynecology. And so I thought I should look for some unusual specialties that maybe don't that I wouldn't otherwise get to experience. And so someone had told me about radiation oncology. So it went to the electives catalog, and I think the story is in the book. And I was trying to flip it to the RA page, and then it just so happens to open to the PU page of public health. So I actually read over the public health elective and thought, oh my goodness, I didn't know this exists, and how interesting. So I actually did an elective that summer in public health and in radiation oncology. And I just loved public health. And radiation oncology for me it just wasn't for me. I mean, there's the patient care aspects, but the technical aspects were, you were calculating radiation beams in usually, like in a dark building, probably in the basement. At least for my elective, it was in the basement. And so it got me so that elective in public health got me really interested. I mean, I started to learn that there was this profession where your work could impact a lot of people all at once. It, brings in issues about social justice and about the public good. It intersects with law through policy. It intersects, and before I went into medicine, I'd considered architecture and law as potential alternatives. And so, the built environment work and the policy work has allowed me really to intersect all of these different elements that were areas of interest for me. Beyond that, though, I think I got involved in chronic disease prevention, in built environment work, and policy work, in large part because after I entered public health, one of the things that I saw was that, many public health departments, local ones, as regional, zonal ones, they focus a lot on infectious diseases. And I'm not saying that's not important to focus on. However, if we look at where the population burdens of illness now lie, they lie in chronic diseases and non-communicable diseases. So heart disease and strokes, rapidly rising rates of diabetes, rising rates of cancers, and then mental health issues like anxiety and depression are also rising. And so, I became very interested. It was very discordant to me that there was so much emphasis on infectious disease control and so little emphasis on the areas of public health that were really affecting us and that were the drivers of healthcare costs, of human suffering, of inequities. And so, I really wanted to address those issues. And then when I started becoming interested in addressing those issues, I really started to think about, well, what are the things that really made us successful in traditional public health issues like infectious diseases? So everything was systematized, right? The environmental component was a really huge component. I mentioned like sanitation, infrastructure, clean water infrastructure. Without those, we'd be nowhere in terms of infectious disease control. Our, cholera epidemics would still be running rampant, right? Crowding and how we design ventilation in buildings. Without those, issues like TB would still be running rampant. And not just having antibiotics, but preventing these in the first place. So it really got me to thinking about all of those elements of public health and public health history that's allowed us to achieve successes. And a really big part of that is our community environments and how we've integrated the prevention of those infectious diseases right into those community environments. That's been crucial. Like, we've got like workforces of public health inspectors that basically go in and ensure that, there's the right temperature controls in every restaurant, that every restaurant has sanitation measures so that people don't get sick from food, from water. We've got measures like, if we're creating a new development, our inspectors are reviewing, those new developments for sewer and water infrastructure. Well, this also presents to us, I think, tremendous opportunities, because wherever we already have public health infrastructure, there's opportunity for us, I think, to move forward integration of these new conditions like chronic diseases into that work. And in New York City, where I was working in Mayor Bloomberg's administration, we did that. We said, you know what? We've got inspectors already going into our restaurants, our daycares. Why don't we get them to collect data for us? And then we use that data. So we worked with our dietitians in our health department, our chronic disease and health promotion professionals. We then created policies using that data. And then when we passed legislation like the trans fat bans, the calorie labeling laws, the new food standards and new physical activity standards for daycares, we got our inspectors who are already out in these premises in the community to enforce those new legislation and new regulations. So it was really very much a partnership between the health protection areas of public health, the enforcement pieces, and the health promotion areas like our dietitians and chronic disease staff who developed those policies using data that the inspectors would bring back to us.
Mm-hmm. I love all the collaboration that that you've realized and recognized through your work. Let's get everybody, as many pieces of the puzzle together so we can have as much impact as possible. So yeah, thank you for that. And I mean, obviously I'm thinking you grew up very active and fit yourself as a young person growing up, and then just found your niche to really inspire and help promote the work that you're doing. And I'm a big believer in proactive. So thank you so very much, for the work that you do and sharing your expertise with us.
I think many of us here are very dedicated to this work, and and I'm grateful to have colleagues like you guys. Like this, there's so much work to be done. As our chronic disease rates continue to rise and our healthcare costs continue to spiral, and provincial budgets everywhere, including Alberta, spiraling out of control because of these healthcare costs. I think there's such an important piece it's so important for us in health to collaborate, but also for folks like Nikki who are working with, municipalities and counties and your partners. We can't do it alone. We can't do it alone individually, because the environments around us impact the choices that we can either easily make or that are very difficult to sustain. And we can't do it alone professionally either. And so the collaborations are so key. And they're so, I think when they're so satisfying too, I would say, the collaborative work. I mean, I love it.
Dr. Lee, it's Heather. I want to thank you for all the time that you've put forward, and to Jonathan too for organizing this event, because I know how much back and forth it was. But there's so many learnings. And I think for me, listening to your talk too, and just what you're saying now, that collective we really stood out to me. Everybody has their assets to bring, but it's such a huge issue to try to improve the health of our society. And I think, a lot of us have heard the message. It's more the onus is on the individual, but just hearing your message and learning more from your book, it's really, I think, important for society to hear that message, to try to change people's thinking that it's not an individual issue, it's so much larger. But I think to be able to tackle it that collectively really stood out for me. So I know we're past 9 o'clock, but I really want to thank the library and Jonathan and just if anyone's interested, I know you've put the plug in for your project too, but you can connect with Healthy Lethbridge as well. So it's just healthylethbridge@gmail.com. We've got our Active Lethbridge website, activelethbridge.ca too, to connect with. And we've got a lot of partners, and we're always open to more partners. And it's Lethbridge and beyond. It's Lethbridge and area. So Warner is welcome too. We've got the U of L Runner Soul and Robbins here from the Primary Care Network to Lethbridge Early Years, YMCA, Bike Bridge. We've got a family center. There's a lot of people involved, organizations. So thank you, Dr. Lee.
Oh, thank you, Heather. And you know, everyone, I've also got, I see Shanike is on on the list here, and Shanike is actually our new partnership coordinator. She'll be starting next week. So you guys who are part of the Housing for Health initiative will be meeting her shortly. So I wanted to just welcome her as well into our Housing for Health team.
Thank you. And like Trish said, we're so happy to have you back in Alberta. We need you.
I'm happy to be back too. Yeah. Okay, well, thank you so much, everyone.
Have a good night. Thank you.
Thank
Bye.
you so much.